First of all, I realized a couple things. I don't have a conflict slide. I have a lot of conflicts, but rest assured, most of them are emotional, and none of them are really related to this talk. The other is I think it's the morning of telling anecdotes about your life and how it relates to why we're here giving a talk today. And I can tell you my kind of interest in pulmonary hypertension was born from a patient when I was a junior attending, admitted a patient with really severe respiratory distress. At the time, had an abnormal CAT scan, and people immediately, and this seemed to be kind of reflexive, but went to this extramedullary hematopoiesis because they had advanced myelofibrosis, this where the blood-forming cells actually invade the lung and interfere with the oxygen exchange. And we kind of, started down that route, but it became very clear early on that that was not what was going on. And she eventually was proven to have a really severe pulmonary hypertension, but it was treatable with a pill, Viagra, actually. And that pill allowed her to walk out of the hospital on feet, no oxygen, when she came in distress. And I remember I was getting, around that time, I ran into actually Stephanie's boss, who is a colleague of mine, a cardiologist, and I was telling him, I saw this patient that had pulmonary hypertension, and it was really bad. And, I read about it, because I did a lot of reading because it was a new patient, a new topic for me. And I was like, it's known that this happens, but we don't really know anything about it. We don't even know if it's really bad. And he was like, well, of course it's bad. Pulmonary hypertension is always bad. And then I talked to, a lot of my colleagues in the MPN field, and we're like, well, just pulmonary hypertension. Have you seen a patient? Because I just saw this really, kind of fascinating case. And people said, well, yeah, we've heard of it, but it's not common. It really doesn't happen often. And, we've never really seen any outcome or, any details. And then I looked at, went back to my friend, the cardiologist, and I'm like, well, should we look into this? So we decided to look into what we had here, which is a lot of what are screening tests for pulmonary hypertension, echocardiograms, that were done for some reason. 99% of them were not anything related to a concern for pulmonary hypertension. And I'll talk a little bit about that afterwards, but it kind of fundamentally changed the way I think about it. I think the way we think about it at Cornell, and one of the reasons why people like Stephanie are so central to our care of MPN patients, due to the complexities of these diseases that interleave a lot of fields in medicine. So this is my cardiology 101. What is pulmonary hypertension? We think of hypertension, somebody puts a cuff on your arm, pumps it up, and measures the blood pressure. That's the systemic hypertension. Pulmonary hypertension, you can't put a cuff around it. If you did, you'd probably go to jail. But it is the other part of the heart. It's all of the blood going through the lungs. The blood has to go to the lungs to get to the oxygen and then to get to the rest of your body. So it's an important part. And pulmonary hypertension is just basically high blood pressure of that other side of the heart. And so, the left side of the heart is really made for the work. It pumps blood through your entire body. It's important for, perfusing big brains and strong legs. And it's really a beefy, powerful muscle, and it responds to increased stress. So people who have high blood pressure systemically, the left heart actually becomes stronger, like almost every other muscle in our body. The right heart is actually not meant for that. The right heart is really meant for a low intensity job. It's thin, it's weak, and it's very important to push blood through the lungs, but it really shouldn't be stressed. And this is I'm sorry, but I like cartoons. I grew up watching cartoons, so my talks tend to have cartoons in them. It's where most of my most important lessons have been earned. But the left side of the heart is a powerful muscle, and it does a lot of the work in the body. The right heart is more of a stamina kind of. It's thin, it's weak. And if you stress that heart, if you ask too much of it, it gets overwhelmed. And this is the problem with pulmonary hypertension. So the first question, which was our original question, is how common is this? Because if you look in the literature, it's all over the place. And so in our Cornell population of patients who had an echo for any reason, so we've looked at every echo ever done on a patient with MPNs. And what we found in those people is more than half of them have some degree of pulmonary hypertension as estimated by echo. And about a quarter of them have fairly advanced pulmonary hypertension. And this is, was kind of shocking to us. And we have, extended this cohorts over almost 700 patients that we've looked at now. And the cohort itself, the numbers just remain fixed. Now, these are people who had an echo done for some reason, so that may relate to why the prevalence is higher than has been seen in some other studies. But the fact that of our patients, those 22%, nobody was paying attention to it when we first started because they got an echo for something else. Is the big beefy side of the heart working? That was the question. Do I have this to push my chemo around? Do I have this because they're feeling short of breath? The left ventricular function is okay, move on. You read the fine print, and they had signs of right-sided failure, even right-sided symptoms. So does pulmonary hypertension matter? And as a friend of mine with PV said to me when we first were talking about pulmonary hypertension, said, great, something else to worry about. So this is, it's something you don't need to worry about, but something that we should be thinking about so that it can be treated early instead of later. And why does that matter? Pulmonary hypertension can cause a variety of symptoms. Dr. Feldman just hit on them, but early fatigue, breathlessness, lethargy, this kind of feeling that I live with chronically. And then later, more severe symptoms. It shortens survival. And this is where, with Dr. Jonathan Weinshaft in the first conversation I had with him, I was like, well, does it matter? And he was like, of course it matters. It matters in everything. It always matters. And this was actually when we were trying to publish our first paper. It was very hard to convince reviewers because we got two reviewers. We got a pool of cardiologists who were like, of course it matters. And then we had a pool of pulmonary, of MPN people who were like, well, could it be explained by the MPN, details of that, why they did worse? And so we just could never thread the needle. You could pick the reviewer, cardiologist, MPN person, basic science. It was a little frustrating. So it went around for over a year shopping before we originally got it published in a cardiology journal. And one of the issues that we focused on is the association between right-sided heart failure. So in even people with mild pulmonary hypertension, we did see an increased risk of right-sided heart failure. So symptoms we talked about this morning. Ruben has led the world in this effort in really quantifying and characterizing them. But the cause of our symptoms, the one-for-one relationship between symptoms and some biomedical event is not very clear, at least to me. And we often associate them with, well, okay, your blood counts are high. Maybe some of that is related to your symptoms, and probably some of it is. Inflammatory cytokines, and cytokines do a lot of things, and some of them make you feel lousy. So that's certainly reasonable, and other things that come up. But this has always struck me when I first looked up, like what kind of symptoms do people have with pulmonary hypertension, and they're exactly the kind of symptoms we have with MPNs. And so it doesn't say that everybody with symptoms has pulmonary hypertension. But what it says is somebody with symptoms, we have to think about pulmonary hypertension as a treatable cause for at least part of those symptoms. And so when we looked, again, this is Cornell data, but when we looked at our patients using fatigue, the most commonly reported symptom at the time the echo was done, patients with even mild pulmonary hypertension had far more frequently were reporting fatigue, and the same was true for more advanced pulmonary hypertension. When we looked at breathlessness, the shortness of breath, the same thing, but more restricted to the people with advanced pulmonary hypertension, which kind of makes sense with the pathobiology. when we looked at right-sided signs of this. So this requires special studies. You don't get this off the regular echocardiogram, but it is an echocardiogram-based measure, so it's non-invasive. But you can actually look at the right ventricle and how it's squeezing, how it's doing its job. And you ever see an echocardiogram? It's like watching an old black and white TV that you have lousy signal, and then that's, we learn things, but they actually look at the little speckles and they track them and see how they move, and that relates to how the heart is functioning. And so that strain on the right heart is measurably abnormal, even in people who have mild pulmonary hypertension. And as I said before, pulmonary hypertension can strain the right side of the heart, can lead to right-sided heart failure. That is usually proximal to people having decompensation and eventually a shortening of life. And so if you look at, this is a subset of MPNs, the same we've recently published is true in people with polycythemia vera. Specifically, we have data coming in ET as well. But that, having any degree of pulmonary hypertension is worse than having normal pulmonary pressures. So it is a useful screening test for evaluating risks. And why do people get pulmonary hypertension, people with MPNs? And so it's really not known. I mean, that's the simplest answer. It's almost certainly not one cause. It's probably many things. These are complicated diseases, as you're all aware, and there's not one thing causing all problems, and that's probably a talk for another day. But what we do know, we published a meta-analysis looking at all of the studies on pulmonary hypertension from at the time that we published this, was with Tiziano Barbui in Italy. And we found kind of two factors that were associated with the identification of pulmonary hypertension. One of them was age, and that's no surprise. As I've gotten older and as everybody gets older, age doesn't make anything better. But as my mother always reassured me that you either get older or you die, so it's the better option. And then the other is MPN duration. And this was kind of surprising, and it shouldn't be a surprise, but it was a surprise at the time, that the duration of the MPN was associated with the risk of pulmonary hypertension, suggesting an accumulating risk. And we look at estimated pressures, again, by echo. Sort of on the x-axis is the years since diagnosis, and what you see that those pressures kind of go up as the time since diagnosis goes up, suggesting a linkage to the duration of the disease. So what's the path forward? Well, we can look to other diseases that are known to be associated with a higher than normal risk of pulmonary hypertension. And this includes scleroderma, a connective tissue disease where the risk is somewhere in the 17 to 20% range. And patients with scleroderma undergo yearly screening for pulmonary hypertension. And the reason why that's done is that identification of pulmonary hypertension triggers now, hopefully better, a evaluation. And that includes referral to specialist centers. So a full diagnostic evaluation that includes testing responses to therapy, that includes hopefully referral to an expert center. And that is an important linkage because outcomes for patients with pulmonary hypertension treated at an expert center are dramatically better than people treated by me, for sure, but general cardiologists even, or non-expert centers. So it's a specialized expertise. And identifying early allows therapy potentially to be started earlier, and that therapy can save and preserve the right heart function. That is the ultimate thing that goes kind of downhill as people do as well. Sickle cell anemia, also much higher risk of pulmonary hypertension, and those patients with sickle cell should be screened relatively routinely, and it's actually an indication for allogeneic bone marrow transplant. So if you have pulmonary hypertension, that meets one of the Seattle criterion for transplant. So that's a very aggressive step, but it's because pulmonary hypertension is recognized as being bad, certainly in people with sickle cell. So in MPNs, the range is somewhere around 10 to 60%. And should we be doing screening? There's no current recommendations for that. echocardiogram is simple. It's easy to justify getting an echo and getting it covered by insurance. All you have to do is say fatigue. Virtually everybody has fatigue. So there isn't really an insurance barrier to screening for pulmonary hypertension. You do have to read the full report and look at the part that talks about the right side of the heart, which sometimes is harder to image, but usually you can get some report. And oftentimes to direct the cardiologist, the echocardiographer, to pay attention to the right, because that's not always the primary focus of people. So always like screening for pulmonary hypertension or interested in right-sided structures. PH should be treated by an expert team. This includes always a cardiologist, hopefully a heart failure specialist with expertise in pulmonary hypertension, identifying the best treatment, as I alluded to before, prevent worsening. Pulmonologists, other, maybe even surgeons are sometimes involved, and that can help treatment specific causes. We looked at our PV cohort to try to understand who should be screened. And so I say I, because I can't say we, because this is just our paper, what we came up with, but I do think something like this is what we should be doing for screening. So people who have symptoms, and what symptoms? Well, a lot of symptoms overlap, but certainly, breathlessness, severe fatigue, things that aren't easily explained or are persisting with therapy, otherwise hoped to be improving them. 70. So age over 70, we found in a logistic model was associated with increased risk of pulmonary hypertension. And then to keep things all S's is 7. So having MPN duration more than 7 years, we found was also associated with a higher risk of pulmonary hypertension. Sorry, this PV, but I think something like that probably extends to ET as well. And just a black box warning, that's my own opinion, and not there is no standard guidance for screening. And then I'll end there. A lot of people, obviously, is a multidisciplinary area of medicine, and a lot of people have been involved. I think I want to just point out, in addition to Stephanie, Evelyn Horn, Jonathan Weinstein from our cardiology group, Alec Godsta published our PV work, and that was in collaboration with a number of other pulmonologists. And then from the data team, Spencer Krzyzewski, who just got his PhD last month, and Katie Erdos and Neville Lee have been involved in this. So thank you very much.